Can we take a little time for a couple questions? Okay, so questions out there. I'll kick one off if we need to. Joshua, you said a little bit about when you were talking about all of us about getting data back to the patients, and we had that question earlier from Adrian about this sort of incentive for patients to participate. And so could you say a little bit, is that in real time that they're getting data back? Do you think that that is incentivizing a bit of participation?
Real time is an interesting word. So when you fill out a survey, yes, you can get those data essentially in real time. We're not the healthcare, all of us is not the healthcare entity. So we could only deliver back the EHR data once we get it. We don't have the mechanism yet for doing that, but the intention is to return the EHR information, return the genetics, and essentially once we have the mechanisms, that will become, should become fairly fast from when we get it to when we can return it. We're still very, very much in the building stage, so all this stuff is in rapid evolution in its infancy. But for individuals that enroll, next year, I suspect that when we get their EHR data, we validate it's actually the right person, we clean it, that sort of thing. It's probably available to the participant before it's actually even available to the researcher, because it doesn't have to come out in the same segments of delays of curated repositories.
Great, thank you.
Hello, my name's John Gardenier. I'm retired a long time ago from the National Center for Health Statistics. And my concern is data reliability, not the statistical kind, and not the kind where you create the data source or control the data source and manage the data all the way through. My concern is with sneakily unreliable data. And there are two types that I've noticed, particularly in these presentations: electronic health records. Some of those were hastily transcribed from legacy paper records by people who had no training, no motivation, no supervision, and no quality control in creating the electronic health records. So there are very definitely random errors of all sorts of things that can happen in data transcription. Another kind of thing is these things appear to be pretty reliable because they function very effectively. But if you think about their function, this measures variations from a gyroscope. That does not necessarily mean a step. I found this records steps when I'm riding in a golf cart. It can easily record steps if I'm sitting in a vibrating chair. So that's what I call sneakily unreliable. I was wondering to what extent you're aware of those, how do you control for them, and so forth.
Yeah, it's very prevalent. I've spent most of my life working with EHR data, and it's got tons of errors with it. But it also has tons of correct information. And one of the things that I would say, in the huge data era, the Google era, one of the things I think that you find is that you have lots of data. If you understand that, yes, it's imperfect, but you have enough signal that the bigger data sets you get, the signal starts to blow away the noise. And some of the noise is systematic, and some of it's different. Sort of difference between sites and errors. One of the things I worry about in terms of like the extra steps from the golf carts, for instance, which is a wonderful example, I think I want to use that again, is if you have a bunch of different devices, for instance, they each have their own kinds of errors if they're all triangulating to the same thing, right? It's the same thing as, the way someone codes in Minnesota can be different than the way they code in Tennessee. And the weather's obviously different, and that can actually lead to differences, things like that as well. And so I think these are all sources of error. However, there are benchmarks out there that you can measure against, and I think it's helps us to and whenever possible to create those. We know how to do that more with EHRs right now than we do know how to do in activity monitors out in the field. But we can look at their association with clinical outcomes and things like that, which I think will be a really important outcome of studies such as All of Us and the UK Biobank and things like that are getting both types of data.
I would just add, in our situation where we have by communication or two-way communication with people using our devices, we have triggers set for reaching out to people to say, was this real? Was this what you meant when you gave this information? Or like I was talking about with the weight data, was this you that stepped on the scale? So there's sort of different ways that we have to sort of validate at least some of this type of data coming in. It's different than the medical record data, but if we think too hard about all the errors, it's easy enough to like go to bed fast because there's a lot of errors in all of the different data sets, I think. But we do our best to sort of validate and trigger validation when we see those types of errors.
I'm Türkan Gardenier, applied statistician for many years. And aside from the very interesting presentations and new modes, as I have learned from listening to you, I had a wonderful time looking at this handout, Landscape of Virtual Clinical Trials. And it talks about trials completed, ongoing trials, and trials planned. And some of the modes indicated were web-based trial design, which I had never heard of, home computer-based, and telephone-based messaging. And I'm curious about them, primarily is related to funding of virtual clinical trials. Are some agencies more prone to or against virtual data collection, or related to reliability problems that might be generated through that virtual data collection? And I'd like to learn a little bit about it from the presentations that have been held so far.
So I think that question we should probably hold till the very end, whether we probably discuss it tomorrow after all of the 4 sessions, because we'll likely, hopefully, touch on some of those points. But certainly during the break too, you can pick the presenters' brains and ask some more specific questions. But that's a pretty big question.
That's a wide field. That is very interesting.
Yeah. So maybe we'll address that after session 4. We definitely have time tomorrow at the end of the formal presentations to really have some thoughtful conversation. So I think we're going to break now. Can we take 15 minutes? Okay, so if we'll return here at 3:20, and then we'll kick it off with our interventional virtual clinical trials. Thanks.